Hello, let's talk about informed consent, which is certainly a big topic in the U.S. these days. We will give you a little bit of an outline of what informed consent is and what it is not in American healthcare. Let's tee it up. We'll talk a little bit about the frustrations of healthcare providers in the informed consent arena. We'll talk about the basics of informed consent, and we'll also talk about the process of informed consent. Well, to top that off, give you a few things to think about of what the issues are on the horizons. So let's talk a little bit about informed consent. Informed consent is usually classified as a form of negligence in the United States. There is a second way that one can pursue an informed consent claim, and that'd be under the theory of battery, which is an intentional tort. For our purposes, we will talk primarily about the tort of negligence, which is the failure to obtain informed consent. In order to give you some background, in a typical negligence action, whether that's a auto accident, some other personal injury, and including medical malpractice, the plaintiff, the patient, must prove that there's a standard of care, that there are damages, and for example, a standard of care would be what a reasonable doctor would do. Damages is that the patient has an injury of some kind. That may be a physical injury, it may be an emotional injury. Almost always it is a physical injury. What people, including plaintiff's lawyers, forget about quite often is this issue of proximate cause. And proximate cause is the requirement that there be a relationship between the alleged negligence and the patient's injuries. Classic issue that I often use with my law students is that I may be standing on Interstate 64, or maybe driving on Interstate 64 at 100 miles an hour, and 5 miles away, someone has a heart attack. Well, that person has damages. Driving 100 miles an hour on the interstate is probably negligent, but there's no proximate cause. There's no relationship. There is no but-for sort of event going on here. And that's what's important for our conversation today. Look at it in the form of what an informed consent case would look like. In that case, a patient has to prove that what a reasonable doctor would have told a reasonable patient, and that reasonable patient, if they had known what the risk was, would have refused the surgery, and but for that was injured. This also can apply to medications these days, that a physician failed to tell a reasonable patient what the likely complications or risk were and benefits of a given medication, and the patient was injured, and they would have refused that medication had they been told what the risks were in the case. In order to prove what a reasonable doctor would have said requires that plaintiff bring an expert witness to testify as to what a reasonable doctor would do. You can put this in the framework of our ethics conversations. Clearly, this is focused on the patient's autonomy of what a reasonable physician would disclose. That's the duty. What a reasonable patient would expect in some jurisdictions, particularly Washington, D.C. in the Canterbury versus Spence case, and that is the patient's rights and under the autonomy model that we've talked about. So let's talk about the frustrations of informed consent. One of the frustrations is, when do you have to get informed consent? And the law gives us absolutely no bright line test for that. What I tell my healthcare providers is that the more invasive the procedure, or maybe even medication or the treatment that you're giving, the more information that you need to give about it. The more elective it is, the more information you need to give about it. Where there are a number of equally likely to be successful options, you probably need to disclose those equally present options. That's can be a little complicated. Certainly in emergency situations, I often tell my law students and my MHA students that it is a whole lot easier to defend a lack of informed consent than a wrongful death case. If you're going to stand around and wait for someone to consent either directly or through a surrogate, and that patient is at risk of dying while you're waiting, you better go ahead and treat the patient. That is just the logical thing to do. The other frustration is damages. How did the patient get hurt? The patient may actually have a very good outcome, but if they would have refused the procedure, if they had known what the risks were, they're entitled to whatever injuries they have because they gave consent without being fully informed. In the case of battery, which is the intentional tort we mentioned earlier, the patient does not have to prove that in fact they were injured. They only have to prove that it was an unwanted touching, that the patient did not consent to the surgery, or they did not consent to the surgery to be performed by the individual that performed it, and they are entitled to whatever damages that the jury would deem them to be entitled to. That's usually not a successful track for patients, but occasionally in outrageous settings, it can be. So let's talk about the basics of informed consent. The basics is talking to the patient about what the plan and procedure is. And this is, I always counsel my healthcare providers that the plan, talking about the plan procedure is part of good patient education. If the patient has a good understanding of what is going to be happening to them, including what the outcome is likely to be, then they are going to be much better prepared for surgery and much less likely to sue the healthcare provider afterward. Are we planning an open surgical procedure that's going to have a 6-inch long incision site, or are we planning a laparoscopic procedure that's going to have 2 or 3 different port sites? Yes, madam, you may not be a bikini model anymore after we get done with this surgery. That may be important to this patient, and it is always important to talk to the patient about what their concerns are. They may be purely cosmetic thing, but it may be a matter of livelihood. The case I defended many years ago involved a patient who had podiatric surgery, ended up with flat feet, which usually would not be a major concern, except for the fact that she was a Secret Service agent and her assignment was to run alongside the presidential limo. So it was important to her to be able to run, something that should have been inquired about. I alluded to earlier, identifying who's going to perform the surgery is important. The patient is entitled to get the surgeon or the interventional radiologist or whoever else is performing the procedure that they want. And that is sometimes easier said than done. If you're in an obstetrics practice, you are not going to be in the hospital 24 hours a day, and you need to have an agreement with your patient that it is you or one of your partners is going to be delivering that baby. It's important to talk to the patient about the risk, and that is a minefield for healthcare providers. It is a balancing of the severity of the risk, meaning how dire the outcome might be if the situation goes badly, versus the frequency of that risk. How often does it actually occur? But you see in almost everyone's informed consent conversations these days that the risk of death could happen no matter whether you're opening your daily mail or walking down the street. And that is an effort to try to cover the waterfront that this patient has in fact appreciated the risk. The bigger challenge, as I alluded to earlier, is do you have to talk with a patient about risks that are specific to that individual. The patient may be very afraid of a particular complication that might occur, and that is fairly unique to them. And so if they voice a concern about that risk, you have an obligation to answer that honestly. Otherwise, disclosure of the risk is a matter of what a reasonable doctor would do under the same or similar circumstances. And that is always where the battle of the experts comes in. Often sometimes overlooked is what's the benefit of this procedure? Is the patient going to walk after the procedure? Are they going to be able to run after the procedure? What does a successful outcome look like? And that's often where we as healthcare providers fall down, is that we forget to talk with the patients about what success is going to look like. In a hip replacement, patients certainly will hopefully have more mobility, but will they be able to ski the Black Diamond ski runs again? Will they be able to do marathons? Again, that's somewhat patient specific, but it is something that the physician needs to take into consideration. Also important is talking about alternatives. What alternatives are available to this procedure? It may be a medical alternative, it may be a different type of surgery, it may be a non-invasive sort of procedure, such as a laser or ultrasound therapy that are being used, particularly in neurosurgery these days. What are the strengths and weaknesses of each of those alternatives that are readily available? Now, an allopathic physician, which is what MDs are called, do not have to discuss the alternatives of herbs and spices and other things that alternative healers may be offering. They simply have to be ready and willing to discuss what mainstream medicine has to offer in the procedure that they intend to conduct on this patient. In talking about the planned procedure, this is a little bit more of a drill down on those things. What is it? What if you get in there and you discover that, ooh, we ought to do something else while we're here? And that is not unusual during surgery, that we go in to remove a fibroid and realize that actually the entire uterus ought to be removed. Should you remove the uterus at that time without further consent from the patient? And this again is part of the conversation with the patient. A strict constructionist would say, no, you have only the right to do what the patient consented to and nothing more. A more liberal interpretation would be the doctor is entitled and almost obligated to undertake related procedures that are there at the time. Certainly in an emergency situation, while the patient consented to have his gallbladder removed, he is not going to be very happy when you wake them up and tell them, hey, you have a bleeding artery right now. Can I repair that too while I'm there? And so therefore, it is sometimes a silly argument. Laparoscopic versus open, we mentioned earlier that in talking with the patient, it's important that one tell them what type of procedure is available and why one is being recommended over the other. It may be that, in fact, the procedure starts out laparoscopically, i.e. we have these 1-inch little incisions and we're putting these long tubes through them and doing the surgery. But it may be that it requires that the surgery be converted to open. And so the patient's going to wake up and they're going to have a 6-inch long incision or longer than what they had hoped to have. Mentioned this earlier about what to expect after the procedure. Very important to talk to patients about what success will look like. Who will be performing it? Again, drilling down a little bit deeper. In the old days, in academic centers in particular, Dr. Jones would be the one who would be the designated surgeon because he was the chairman of the department. But it might be any of the other faculty or even house staff, residents, interns who might perform a surgery. That's not acceptable today. Patients are entitled to know what physician or surgeon will be doing that procedure. Likewise, if a significant part of the procedure is going to be conducted by someone other than the surgeon who's talking with the patient, that needs to be disclosed. And often that is very important that they do. That it is a big surgery, requires multiple sets of hands, may require multiple surgical teams. And so that should be discussed with the patient. Drilling down a bit more on the risk, always the question of how do you calculate those? Is it, is a 1% risk need to be disclosed? And when you say 1%, whose 1% is that? Is that 1% from all comers, something that can be published in a national journal, or is it in your hands, a 1% risk? If you've only done this procedure 10 times and you've had one complication, then it's 10%, which is probably distorted. What are the benefits to the patient? And this is drilling down a little bit again on the same topic. Very important to talk to patients about what they're going to look like down the road. Also, equally important is to explain to them, okay, if you don't want this surgery or you don't want this intervention, what's the risk? What's the downside of not doing this? And that obviously often is the persuasive point as to why patients consent to a surgery or to an intervention of some kind. But it is very important, and occasionally we do see situations where the patient claims, I didn't have the surgery because the doctor didn't tell me it was necessary, or that I would suffer any consequences for not having it. Drilling down a little bit more on the alternatives, need to certainly talk about different procedures if they are reasonably available and are reasonable alternatives to what you're proposing. Today, there are a number of ways to achieve the same result. Many procedures may be done by surgery, but they may also be done by interventional radiology in a less invasive manner. It may be that medication can accomplish the same goal as surgery would, or vice versa, that surgery may cure the need for medications. We see this in bariatric surgery, for example. You don't have to talk about the herbs and spices unless the patient brings them up, and it is certainly not the allopathic physician's obligation to go out and become an expert in alternative medicines. That's up for the patient to go find. So let's talk a little bit about the process. It is the obligation of the surgeon or doctor, physician, who is going to be performing the procedure to obtain informed consent. That can be delegated to a nurse practitioner, to a nurse educator, to a lay educator, if one would like. It cannot, however, the ultimate obligation remains with the physician. And the classic signing a consent form and handing it to the nurse and saying, go get consent, it just doesn't cut it. It is the physician's obligation to obtain that informed consent. They can certainly delegate it, and sometimes that actually is a very good approach of having the patient meet with an educator who can show them videotapes, give them handout material, answer any questions they have, really have a very good bedside conversation with the patient. That's all well and good. Eventually and ultimately, it's up to the surgeon or the doctor to assure that informed consent has been obtained. The issue also comes up as to did the patient understand? And that's the challenge with written consent documents, is that they are often terribly complex, and they are almost never read, just as nobody reads the software packaging disclaimers. And so the question always becomes, was the information conveyed to the patient? And conversely, did the patient understand that information? This is particularly important and sometimes embarrassing when you have an LEP patient who signs off on your consent form and you claim that you got informed consent, but they only speak Spanish and your form is in English. Many people like to assume that if the written consent form is signed, then all is good. The problem is that it isn't. A written consent form is at best a documentation that the conversation was had, that the patient has had the opportunity to ask any questions or concerns that they have, and that the patient is ready to go. But it does not replace the process of the healthcare provider talking with the patient and assuring that the patient understands what is being planned, what the risks are, what the benefits are for that procedure. Certainly a patient in America under our autonomous model has a right to refuse treatment in most circumstances. If they do, then your risk management department is going to tell you, well, does the patient have capacity to consent? If they are delirious and they're refusing because they think that you're going to place a snake in their abdomen, then they probably don't have consent, or I'm sorry, don't have capacity. And you need to figure out how one goes about obtaining consent through an alternative means if necessary. From the risk management perspective, you want to be documenting very carefully that you did have the conversation with the patient, that they know what the risks are, they know what the benefits are, and they also know what the likely outcome of refusing the treatment is. That if the risk is dying, they need to be well aware of that, and there's no pussyfooting around that situation. If they are going to be crippled, they may lose their leg, or whatever the infirmity may be from refusing this procedure or this medication, they need to be aware of that, and you need to document very carefully that was in fact done. It is always nice to have the patient sign off on that, but sometimes they just aren't that cooperative. Let's talk a little bit about the issues that are coming up down the road. Some of them are here, some of them are well off in the future. As I alluded to earlier, getting informed consent is not just for surgeons anymore. Certainly that is the classic model, but interventional radiologists need to be equally aware of informed consent. Anyone doing invasive procedures needs to be aware of the informed consent conversation, but likewise physicians, i.e. non-surgeons, need to be having the informed consent conversation whenever they're prescribing medications. And again, routine, fairly benign medications, probably not so much of a detailed conversation needs to be had. But for a medication that has known side effects, that does have a high risk profile, that conversation needs to be had. And the patients certainly appreciate handout material to take home with them, whether you're talking about surgery or about medication. But if you're prescribing medications with a high risk profile, you need to be having a very detailed conversation that also hopefully will improve patient compliance in taking that medication. An issue that occasionally raises its head is there an obligation for the surgeon to disclose how many times he's done this surgery? If this is the first time you've ever done this surgery, that probably needs to be disclosed. If it is the 100th time you've done this surgery, probably not that big of a point that needs to be considered. But if you just came back from a weekend workshop and learned how to use this whiz-bang piece of equipment, whether that's the Da Vinci robot or a new laparoscopic toy that you have or something else, you probably need to disclose that to the patient and let them decide whether they want to be number one or not in your books. A question that does come up, and I alluded to it earlier, is when you talk about risk, are you talking about risk in general for all surgeons, or are you talking about risk for you as a particular surgeon? I defended a surgeon one time who she had done 10 laparoscopic gallbladder resections. She had 4 complications out of those 10. That was extraordinarily high, considering that the national average is probably somewhere around 3%, i.e. 3 out of 100. And so, yeah, probably in those circumstances, one could argue that she did have an obligation to disclose that she was not as successful as most surgeons in this surgery. An interesting question that pops up occasionally is how much does the surgeon have to disclose about themselves? If the surgeon has only one eye that they can see out of, that's going to affect stereotactic vision, and that may be important in surgery. They may have a tremor, which is, if you're doing eye surgery especially, tremendously important that you not have a tremor, even though much of those procedures are now automated. But do you as a surgeon have an obligation to disclose that sort of thing? It may well be that if it is something that is certainly pertinent to the safety of the surgery, then maybe you do. Do you have an infectious disease? This came up back when HIV was first becoming known. And occasionally surgeons would be HIV positive, and the question was, did they have an obligation to disclose that to patients? Illinois, the state court in Illinois, initially said that in fact they did have an obligation because a reasonable patient would want to know that information, or conversely, a reasonable patient or a reasonable surgeon would disclose that. Last but not least is there anything affecting your recommendation? And this has become kind of a hot button as far as spine surgeons, for example. Some of them will recommend that a particular device be used in their surgery, and in fact they have a financial interest in using that device because it's one that they invented, or it's one that they are through a labyrinth of corporate organizations are actually profiting from selling to the hospital. There may be some other interest that the healthcare provider has that should be disclosed, that may be influencing why they're recommending this. That's the end of our section on informed consent. I hope you've enjoyed it. I hope it sparks a few ideas. And when we start into our discussions later on, we'll be doing follow-up follow-up PowerPoints on informed consent for children and situations where a patient cannot consent to a healthcare procedure.